Hi, and welcome to an education session held by the Loddon Mallee Regional Palliative Care Consultancy Service. My name is Jo Lane Welsh, and this is my colleague Anita Wild, and we're nurse practitioners in the service. Today, we're going to be talking about comfort care in the emergency department. I would like to take this time to acknowledge the traditional custodians of the land on which we meet today and pay my respects to the elders, both past, present, and emergent.
Okay, so comfort care in the emergency department. So palliative care is person and family centered care provided for a person with an active, progressive, advanced disease who has little or no prospect of cure and who is expected to die, and for whom the primary treatment goal is to optimize the quality of life. So that's a definition that's come out of Palliative Care Australia. And so I suppose what some of the things that we're emphasising and looking at there is that we should be strongly responsive to the needs and preferences and values of the people, their families and carers. And so we do tailor a lot of our care to, patients' goals of care and what it is in which that they're looking for. So this approach is based on effective communication, shared decision-making and personal autonomy. Palliative care should be available to all people living with an active, progressive, advanced disease, regardless of the diagnosis. And so we don't just look after patients with cancer. We do look after a lot of non-malignant patients, whether that be the respiratory illnesses, renal, as well as progressive neurological diseases. Palliative care affirms life while recognising that dying is an inevitable part of life. This means that palliative care is provided during the time that the person is living with a life-limited illness, but is not directed at either bringing forward or delaying death. So when we look at palliative care, we look at phases of care. And so this may be how we in the community would look at when we would visit patients and where they might be in their trajectory. So if a patient is stable, if they're presenting to ED, they're very unlikely to be in this phase. So a patient in stable phase is unlikely to have any symptom burden at that time, is relatively doing well, maybe receiving some treatment depending on their diagnosis, and is living life quite well with their families at home. A patient in unstable phase, so this is where anything immediately reversible, even if the patient is a palliative patient. So a patient in unstable phase may present to the emergency department with a delirium. They could have a pain crisis. They may, be in urinary retention. They potentially may have developed a bowel obstruction. So again, because the patient's been labelled palliative doesn't mean that we don't investigate. So a patient in unstable phase, we'll be looking at reversing the reversible. So doing a simple blood test, are they hypercalcemic? Do they have a urinary tract infection? What is the root cause of their confusion? Are they having a pain crisis? Have they had disease progression? So we're looking at what has contributed to them requiring an emergency presentation. A patient in deteriorating phase. So this patient doesn't necessarily require urgent intervention. However, they may present to the emergency department with a functional decline, their family is not being able to care for them at home, they've got that increasing care requirements, or they may as well have some disease progression. So it's investigating how we may be able to help this patient. Are they requiring increased community support to be able to get them back home? So looking at increased referrals to community pal care teams, to district nurses, potentially heart programs, what services are available? Are we able to get equipment into the home to help the family as well? Or do we need to look at an admission to then look at placement of the patient if that's where their trajectory is headed? And then the terminal phase is typically looking at that last 1 to 3 days of life. So, there would be a change in the patient. They may be becoming less alert. Their function would be declining. They may be spending more and more time in bed, having difficulty swallowing, and the family may notice this. If they aren't prepared and able to keep the patient at home, they may present to your emergency department. And so then it would be, where is the most appropriate place to for this patient to have their terminal phase of care? Is that back home with the appropriate medications? Do we need an inpatient palliative care admission? Or is the patient too unwell to travel down to the palliative care unit, that we would admit them up to the ward?
So we're going to have a little look at some cares, sort of caring for the patient. So looking at comfort, airway, restlessness, emotional support, and self-care. Okay, so we're going to have a little look at comfort measures. Of course, pain is one of the first things you think of when you're looking at providing comfort. So if possible, we would continue with the oral medication if that's what the patient is actually tolerating and absorbing at the time. Certainly, if someone's come into ED and if they are in a pain crisis, it is worth considering whether they are actually absorbing the original medication that they're having. So even if they're not vomiting, are they actually absorbing it? If not, we would actually recommend subcutaneous route for administration of pain relief. Either PRN or via the continuous subcutaneous infusion if required. And of course, we'd look at, if they are on a background of oral medication, rotating them across to an appropriate level for subcutaneous use. In terms of pain control for palliative patients, there's actually not really a maximum use of opioids that we would be concerned about. I guess what we're more concerned about is that if a patient is requiring more than 3 doses of a PRN medication and at 30 minutes apart, and it's still not working effectively to provide relief for this patient, then we would need to consider, okay, is this patient absorbing? Is there actually a change in the condition of this patient that's meaning that the pre-existing medication that has been working is no longer effective? Is this pain a different pain that actually isn't going to be responsive to opioids, and do we need to consider something different? Is there some renal failure that might be occurring that's changing the effectiveness of that medication? Or is there anything new or reversible, as Anita had mentioned before, about reversible changes in condition that may need a different approach to comfort measures there? So they're all the things that we would consider if the pre-existing PRNs, even if they're given via a subcutaneous route, are no longer effective. If the patient's pain is no longer responding to the pre-existing opioids and all those other things are ruled out, then it would be worth considering whether there's a better and more effective opioid that would work appropriately. And we do see this a lot, particularly with patients that may have been on Targin or something like that, and they've actually developed some liver involvement, and the naloxone component is now going to be outweighing the oxycodone component, then a change to just an oxycodone is going to be more effective. So we do see that these things can adapt as disease progresses, and a change in opioid is effective. There's also a lot of fear around giving opioids, feeling like you're going to be giving that final dose. And when you're caring for a dying patient, that the potential of giving that and then holding off and actually having people in pain because of fear of giving a final dose. There is always going to be a final dose. And it's not going to necessarily be the dose that's going to have any impact on the fact that that patient is dying from their underlying disease. So that's where keeping in mind the legal and ethical concepts of intent. So, you're looking at providing comfort to this patient. Another dose is appropriate and reasonable and has been effective. And if it coincides with the death of a patient at that time, it is likely that it is the background disease that is progressing and having an impact on the patient's body and ability to cope, not the medication. So yeah. In terms of comfort, the other things to think about, apart from just the medication that we give for pain, is to avoid unnecessary procedures and tests and activities that may exacerbate discomfort. So, if you don't need to take that patient off to have another test, is it going to inform anything further that you're going to do for that patient? Then it's probably best to avoid some of that, because it can certainly, the movement can exacerbate pain. It can also exacerbate nausea, vomiting, and distress. Have a look at stopping or modifying the amount of monitoring that you do with patients. Turn off any of those monitors that are going to bing and make noises if it's not necessary to actually take those vital signs at the time. And if it's not going to inform anything further with what you're doing. We would look at ceasing unnecessary oral medications if a patient's really having trouble swallowing oral medications. There certainly are some things that we would rotate onto subcutaneous for like management of nausea, vomiting, anxiety, seizure prevention, that sort of thing. But if a patient's on antihypertensives, it's not going to have an impact at that point. Stop or wean any tube feeding that may be going on. Now, we don't see a lot of this with our patients coming in, but if you've got some patients that do have a nasogastric place and have been being fed, then having a look at appropriate weaning of that. If a patient's deteriorating, they're going to have problems absorbing the food that's going in there anyway. So it is appropriate to reduce that down, which will actually provide more comfort as well. Discontinuation of isolation, that's looking more at if you happen to have an immunocompromised patient. I guess isolation is certainly something that's a very big thing that we're dealing with in COVID times, and it is having a massive impact on the way that patients and families are managing and navigating the hospital system. And of course, safety to other staff and other patients is very important. But if you're looking at a patient that is immunocompromised, but they're actually at end of life, then the impact on them is going to be much reduced, and allowing family members to be in with them is important if they're able to. Turning and positioning, looking at comfort for turning, positioning, pillows, that all makes a difference in terms of just taking the pressure off your backside, moving onto the side, and if there is an air mattress, that can make a difference as well to providing some comfort and taking the pressure off. As we know, anyone lying in bed for any length of time, just the lying in one position is uncomfortable anyway. Modifying bathing, so using sort of different techniques to minimize the movement for patients while still providing that care that is needed. That can have an impact as well. Frequent mouth care, it can be very uncomfortable when patients their mouths dry out, and just providing that regular frequent mouth care can provide a lot of comfort. And also, if family are able to be with them, it can give them the opportunity to be able to do something for their loved one and be involved in their care when a lot of the other stuff, particularly when they're in an ED department, a lot of the other stuff they can't do, and they may have already been providing a lot of care for this loved one at home. So allowing them to be able to continue with some of that management. If family are around, explaining what you're seeing, the changes, the modelling, the cyanosis, explaining that is actually part of the dying process, rather than someone actually being cold and uncomfortable. A lot of fear can come out of observing what's happening to your loved one, and seeing these sorts of things can be quite confronting. So just having those conversations and being available to talk regarding that can help a lot. And always talk to the patient and the family around the changes in position, even if the patient is actually unconscious, talking through what you're going to do, giving them the heads up, you're going to roll you onto your side now, just helps to take away the fear of what's going on.
So looking at airway management in palliative care, of course, when we're thinking of airway management in emergency department, often it may look a lot different in terms of patients being intubated. We may be looking at, using high flow oxygen and different things. So for a palliative care patient, the use of oxygen should only be used in a hypoxic patient, which is the same for any of our patients. We often see, nasal prongs popped onto a patient who presents with a bit of dyspnea, to try and provide that comfort. However, if their oxygen saturations are still sitting above 92%, this is actually going to be quite ineffective for their management. And then we often think about trying to get this patient home. If we've kept the oxygen on throughout that entire time, we remove it just before heading at home, it can often give the patient and their family a little bit of anxiety as to why we're not getting oxygen at home. And so it's just those things, those small things to consider. Of course, if a patient is desatting on room air, then we will require oxygen supplementation, which is able to be provided at home. However, there will need to be some testing and some prescribing of the oxygen as per the policy on prompt. So the way in which we would manage dyspnea in a breathless patient is always to consider that non-pharmacological approach first. So thinking about ways in which this patient is presenting and how they're looking to use. So the use of a fan, whether that be a ceiling fan, a handheld fan, a pedestal fan, or even asking them at home to open up the window and just having some breeze if it is a nice windy day outside. Just that feeling of that increased airflow can often help to calm down a patient. We also have some respiratory receptors on our face where the pointing the fan, if we've got a handheld fan directly onto our face, cools down the respiratory receptors, as well as then, applies that calmness to ourselves. It also can be seen as a distraction method. And I guess so if the patient is quite breathless and they're having to hold onto this fan and concentrate on this blowing into their face, giving them that increased airflow, then that can often distract them from that sensation and feeling of breathless. And it is quite an effective tool that our patients do. It's ineffective. It's cost effective and it's got no side effects. So absolutely something that we should be using. Another thing to consider is a lot of the patients who are sitting in a bed, they may be sitting out in a chair, is their positioning. Are they slumped over in the bed, decreasing their diaphragm, not actually able to take in a proper breath? And then what we tend to see is the patients are just doing short, shallow breaths because they're actually unable to expand that lung field. So there's numerous times that we'll go and do a ward consult. The patient will be being assessed for breathlessness management. We will see that the positioning of the patient at the time is inappropriate for them to be able to take in a nice deep breath. So educating the patient to try and sit them up, get them to take some deep breaths if they're able to, and ensuring that we're always considering pressure area care and moving the patient around the bed as much as possible. We can then move on to some pharmacological management. So a lot of the medications that we try to use is looking at some low dose morphine as the preferred opioid of choice. Obviously, we would need to consider patients with renal failure. However, given a small dose, so when we're looking at dosing for breathlessness, the morphine dose is capped at a maximum of 4 milligrams. So we would usually use 2 to 4 milligrams orally, or 1.25 to 2.5 milligrams subcutaneously. And so the idea around the low dose morphine is to try and help relax the airways to enable us to get a better control of our breath, as well as help with that exertional dyspnea as well. There has been some studies that are showing that low dose, long acting morphine has also been quite effective in the management of breathlessness. And Kapanol has recently been placed on the PBS for this indication. So that is capped at 30 milligrams in a 24-hour period. And we do tend to find that patients that just start on 5 milligrams twice a day do start to get quite a good response to their breathlessness management, and find that their exertional dyspnea does in fact improve. So when dosing of the Ordine, generally you would try and use the PRN immediate release morphine 20 to 30 minutes before activity. So if you're thinking about getting the patient up to go and have a shower, but they've already experiencing quite a bit of breathlessness, then giving them a dose of the Ordine about 20 minutes before getting them up and walking them to the bathroom, or even if you're popping them in a wheelchair, that exertional effort of having a shower can be minimised slightly by using some of the Ordine. Bearing in mind that it doesn't work always the first go, and sometimes we do need subsequent doses, and encouragement, like encouraging the patient to ask for it further, and they'll see some benefit over time. What we often see with breathlessness is that associated anxiety. And of course, if you're struggling for breath, often the fear of becoming breathless. And a lot of our COPD patients who have had an exacerbation of breathlessness, will often describe that sensation and that inability to be able to catch their breath, and they fear that that's going to be their last breath that they take. So the anxiety component then starts to take over in these patients, and it's difficult to try and get someone to take slow, deep breaths when they are quite anxious. And so sometimes an anxiolytic can be quite effective for this, and we would generally use lorazepam, 0.5 milligrams to 1 milligram every 4 hours as needed. Some patients find that knock day breathlessness quite debilitating, and they find that that fear of going to sleep at night time in particular overburdening, and so often they may have a regular dose of 0.5 milligrams of Loraz before going to bed, and this tends to just sort of help with their ability to get to sleep. If the patient for some reason is not able to take lorazepam, then we can use 2.5 milligrams of midazolam. However, we prefer to use the sublingual route in the first instance. Another consideration in airway management for a patient who is heading towards their terminal phase of care would be to look at terminal secretions. And so not every patient develops terminal secretions. Often we might find patients who have had pre-existing lung conditions may have one of those moist chests, and we might find that they develop it a lot more than a patient who might have ovarian cancer, for instance. However, it is something to consider, particularly if we have been giving the patient fluids quite recently in their disease trajectory, and they may have developed some renal failure and not being able to get rid of that fluid. So I guess one thing that we do need to consider is normalizing that process. The terminal secretions are a part of the natural dying process. What we tend to see is that it's more of a pooling of secretions, and the sound is that vibration of the air going over the top of that pooling. So for patients' families, it is quite an uncomfortable sound to be listening to, particularly at the bedside. It sounds as though the patient is drowning, depending on how severe the secretions are. Naturally, terminal secretions are quite a poor prognostic indicator for the patient, and we usually look at that then, someone having around 23 hours of life, obviously give or take, depending on the patient. So ensuring that the patient's family are as comfortable as possible. We might also notice some irregular breathing, which we see quite a lot when we're heading towards the end of life. So that could be quite erratic, really short, sharp, increased breath breathing, and then we may see increased periods of apnea. So we sort of get what we see is that O and Q signs. So you might sort of see the patient sort of with their mouth more open and trying to take the breaths, and then as they have those decreased breaths, then they sort of start to their mouth will droop more down, looking like a bit of a Q. And so obviously it's difficult to know for the family when a patient stops breathing, is this actually the end? And so educating them around the breath cycle, and so that when they're having those periods of apnea, that's because there's that increased carbon dioxide. So they have that, period where they've stopped breathing and then they're needing that oxygen drive. So we're having that really quick increased breath to get our oxygen in. And then we have that drive where we stop again. So it's that ongoing circle. Ways to try and manage the terminal secretions is, again, non-pharmacological management is always best. So looking at position changing, fluffing the pillows, really good nursing care is what we're after here. And so we see that a lot, don't we, Joe, where we're really needing to just turn the patients from side to side, and that's kind of the best management for that. And as we're shifting, because we're not able to cough as the patient in that terminal stage. Again, talking to the family, educating them on what is occurring, and to try and get them to keep calm. Stating that the patient isn't actually distressed by these secretions. They're not, it's that sound for us, but it's not actually impacting on their breathing. So we can actually use some medication should we need to. So the anticholinergic medication, generally in the hospital, we would use glycopyrrolate, as it's a non-PBS item. And then if we were sending somebody home, we would look at buscopan because it is a lot cheaper on the PBS. It is important that we only use this medication in an unconscious patient, because it will dry out, not only the secretions, it will dry out their oral mucosa, their GI tract. It can increase the risk of urinary retention. It can slow the bowel down, dry out our sweat glands. So we just need to consider that as well. Often if we use the medication in the first 24 hours and it hasn't been effective, it's not going to be effective. It's unfortunately not a medication that has a great success rate, but it's just something that we're able to provide for comfort for the patient and for the family.
So looking at restlessness, this is not an uncommon symptom that is that we see in dying patients. So it's just that agitation and distress that you see in a patient that their trajectory is changing quite significantly. Of course, the first things to look at is to rule out anything that might be providing that distress or making that distress worse. So ruling out constipation and urinary retention are really important. I think particularly urinary retention, it's really, you can't medicate away that sort of distress that you get from having a full bladder and how uncomfortable that makes you feel. So definitely having a good look at that early on is really important. Of course, the pain element, particularly if a patient's not able to talk to you, it is worth just making sure that they haven't got extra discomfort or pain, whether it is worth giving a breakthrough dose and monitoring the effect of that. And also having a look at any change in medication. Perhaps there's been a different medication that has exacerbated that restlessness or distress. So ruling out some of those things first up. So as I've said, with that, consider trialing some pain relief, even looking at whether it is something different that you need to try. We certainly see that some of our patients can become quite delirious, and an antipsychotic like haloperidol we find can be very effective for delirium. And it also has the added benefit of, if there is a little bit of nausea, it can have an impact on nausea as well, which also can cause some distress, particularly in a patient that's not able to talk to you that well or explain how they're feeling. In terms of benzodiazepines that can be used to help settle a patient down, if we've ruled out all those other elements, is, as Anita has mentioned, lorazepam. Sublingually is effective and can be used in the home setting as well quite easily. Of course, be mindful of the fact that if you're using a sublingual medication and the patient's got a very dry mouth, it's not going to be so effective at being absorbed there. So midazolam is the other option, and that can be given subcutaneously. Have a look at how calm the environment is. Now, we're talking about patients that are coming into the ED department. It's very hard, and we understand it's very difficult to be able to control that environment. But I guess if we can have a look at minimising how bright the lights are, pulling some curtains around, seeing if you can have someone, a loved one with them, to be able to provide that sort of sense of orientation, or someone familiar can make a difference. Those sorts of things, even some background noise, whether it's music or something like that in the background, that can just take away from the other sounds that are around that may be a bit distressing. Discuss with the family any comfort measures that may have worked for this patient when they were. This is in a patient that you can't really communicate with that well. So, something that might have worked at home that might provide some comfort or relief. Whether there is any spiritual aspect that's important to this patient, whether it's a particular music, whether it's providing for someone, for a minister of religion, to be able to make contact. Now, again, COVID times has made this all very, very difficult. However, we do have access to pastoral care, spiritual care, and there is always FaceTime and things like that can provide some support as well there. Looking at aromatherapy, again, difficult in the ED department, but if there is a certain smell that provides comfort, even if family members are able to bring that in, and you can make that available to the patient, so it becomes a familiar aspect of something that is known to them, particularly in a patient that can't quite psychologically work out what's actually going on or orientate themselves. Sometimes smells and sounds can help them orientate as well. Discussing with the family and the patient as able, any potential unfinished business that might be there. So is there someone that the patients has been waiting to see? Are they holding on for something that's important? Do they need to be told, hey, it's okay? Is that exacerbating some distress and restlessness that we're not going to be able to medicate away from either? Restlessness, agitation, delirium, all of this is quite scary to family. So if we have got a family member watching on or around at the time, normalizing this process, that this might be part of that dying process, and that this is not unusual. Pointing out that the patient often is unaware of their distress and agitation, and looking at different strategies to manage or minimize the distress can go a long way in helping to settle how family feel watching on.
So providing emotional support to the patient and their family is quite an important part of someone's end-of-life experience. And so it is important to look at the emotional, spiritual, psychosocial and cultural support, as Jo mentioned, for the patient. Ensuring that we are always maintaining the patient's dignity and they're making them always feel valued. So, you know, even up until that last breath, ensuring that when we're talking to the patient and their families that, you know, we're always explaining what's happening, asking if they're okay, is there anything that we can get them, and you know, involving them in everything that we can. Looking at individual care, and every family is unique and they all grieve differently. You know, some people are quite private, they may not wish to be present at the time. Patients, you know, often have that emotional cue as well. And I know throughout my time working not only in palliative care but in cancer nursing, there's been multiple times where family have spent hours and hours sitting by the bedside with family, and they may get up, you know, to go and make a phone call out of the room, or they may go and make a cup of tea, or just to go get some fresh air. And that's when, you know, the patient may die. And I think that that's just the patient's way of protecting the family. But, you know, that can have an impact on the grief and bereavement of the family, because if they felt they needed to be there, then they weren't. And so, you know, just allowing them and letting them know that it is okay, and this is the patient protecting them. Again, with everything, through symptom management, through, you know, discussions with family, whether, you know, they're coming in with a broken leg, or if they're coming in for end of life care, you know, good communication in healthcare is the key. And so ensuring that we're looking for those cues from the family. We shouldn't assume that we know what they're thinking or feeling. Just because their body language is portraying one thing doesn't mean that that's how they're feeling. They may try and be very stoic towards the end of life, but they're, you know, all they're trying to do is hold back some tears. So allowing them and letting them know that it's okay to cry, it's okay to show that emotion. You know, it's a highly it's a heightened sense of emotion at the end of life, and no one knows how to respond or to react. And so allowing them to be individual and doing it in their own way. I guess it's important as well to clarify how much the patient and or the family want to know. Some people want to know everything. They want to know exactly when the last breath is going to be. They want to know, you know, how is this patient going to die? And others are just happy to sit there and be comforted, you know, and talk to the patient and just to be there with them. And they don't want to talk about death. They don't want to talk about any of that. So ensuring that we're providing appropriate care in that way. I think it's important to acknowledge that the person is dying in the first instance, but we don't need to go in there and reiterate that every single time that we go and have a conversation with them. They're aware, you know, but it's ensuring that we are all on the same page. And I guess as well, clarifying those goals of care. So where is it that the patient has wanted to die? You know, how, if they do present to the emergency and they may be in the unstable phase or that deteriorating phase, what are the goals of care in terms of how much investigation should we be doing here? And so ensuring that, you know, that communication is there, that we're discussing, you know, if they're a cancer patient, we're discussing the treatment options with their oncologist as well. And it may be that the oncologist has decided that, you know, that this is likely disease progression. You know, I don't think we should intervene. And so having then that conversation with the patient and the family is going to be an emotional conversation, because that essentially means that there's no further treatment options. And so thinking about the approach that you take when having that conversation, as well as how are you then going to support them going forward. One of the most powerful things that we can actually do is just to be present and listen. Particularly if the patient is heading terminal. It's really important that we do have that ability to actively listen to our families. And I think that's one of the best parts of working in palliative care, is that we do have the time to be able to sit down and to listen to their stories, to answer any questions that they may have, and just to really ensure that we are hearing what they want us to hear. And so validating what they're saying and ensuring that, you know, you are answering their questions appropriately. If you don't know the answer, that's fine. Just be honest. But go and have a conversation with someone who may be able to then talk to the patient or the family about what's happening. And just acknowledging, the pain that they may be feeling, that grief and that anxiety as well. As Jo mentioned as well, it's looking at the rituals that the patient may want, those religious needs, and pastoral care. So it is important to try and, if we do acknowledge that the patient is terminal, that we try and intervene on that earlier rather than later, because it can take some coordination, particularly in COVID times, to try and get somebody from the patient's particular religious background to be able to come in and provide, if they can come in, to provide that support that is required, or to, do a Zoom or a FaceTime as well. Ask whether there's any music that we may wish to be played in the background. They may have a favorite band that they'd like, played at their end of life. Often, if a patient has an advanced care directive, this may be written in there. So it could all be at our fingertips. We just need to go and find it. And so reviewing the advanced care plan, providing gentle massage. This is something that we could get the family to do as well, a bit of a foot massage, a hand massage while we're sitting there. And to try and turn the clinical area, if the patient is in the ED, into as much of a home space as possible. And I know that is a challenge because it is, not a small unit, but the cubicles are small, or the individual rooms aren't often overly big, but allowing family, if we're able to in non-COVID times, access to come in and out and to be there with the family, or looking for a more appropriate place of care if we're able to get a bed elsewhere. So we just need to remember that we are caring for another human being. So yeah, your humanity is what is needed most. Just being available, and if possible, your presence is calming for the patient and family. Be approachable. As I said, answer any questions. And yeah, just reiterating that it is okay if you don't know the answer, but please go and find somebody who will be able to answer that question for them. And that just gives the family a little bit of relief. Always consider privacy, as Jo said, lowering that lighting, removing any unnecessary equipment from the home, from the room or the cubicle, because that just makes it more of that calm sort of home-like environment.
Thanks. And talking about self-care, how do we care for ourselves when we're caring for so many patients and patients right at that end of life, and the impact that can have on us and our colleagues? So I guess recognising that different patients have different effects on us all. I'm sure, Anita, you've had this experience as well, but certainly for myself, I've found that you can travel along and you have care and empathy and understanding for all these patients, but there's always one that gets through just that little bit further than you expect. And it's really important that you acknowledge that, oh, okay, that one sort of sat a bit closer to home. There was some sort of understanding of some way our walks in life are similar, where they've managed to sort of get through to your heart a little bit in a different way. And while you're still professional and you're still providing that care, it can impact on how you feel, and you can carry that along with you a little bit further. So recognizing that some do get through more than others, and that is okay, but also recognizing that's really important to actually have a chat with someone else about that. So certainly in terms of as a team, reviews and debriefing can be very valuable, particularly if there's been a really distressing death that the team have had to deal with. So recognizing the stressful elements of it, having a look at how well the team has actually worked together to care for this patient, and what they did do really, really well, and how we pulled together at that time. So recognizing and reviewing what went really well, and also acknowledging, okay, what things were challenging, or what things do we think we could have probably done better, and recognizing that as well. Share the comments and feedback from a bereaved family. So, you might spend hours looking after a patient, your shift finishes, and in the next shift, is when the patient dies, and you come back to work the next day and think, oh, okay, so they've gone. But it's really wonderful to hear that the family were able to walk away and often say, hey, thank you so much for all everyone, what everyone did, and can you please pass on to Anita, who was caring for my mum in the shift before, that what she did was really important. So sharing these comments is a great way of actually having some resolution, I guess, for yourself when you're caring for someone else. Recognize that there is actually a lot of moral distress issues that are apparent, particularly through COVID times. And, I guess we're all very aware of the impact that this time is having on family members and on patients, and how separate we are, and the impact that can have on what you would really ideally want for a patient and what is the reality of what we can give. So recognizing what we can do and what we can change for a patient and family and their experience, and recognizing that unfortunately there's things that we can't change at the moment, and these are things that are outside our control. It still may not be what we'd optimally want, but let's look at what we can give and the best that we can do. Recognizing the challenges and privileges of caring for someone through that dying process. It is a process that is so important to, and so wonderful to be part of, and it can be distressing at times, but it also is a privilege to care for someone as they are leaving this world, and to help a family walk through that as a unit. And what we can do in that dying process can actually have a really big impact on the bereavement process for those who are left behind. So there's a lot that we can do that goes on to having an impact for families and loved ones as they walk away and start life in a different way as someone has already left. Reflecting on your care and the impact it's had on a patient and on the family. So important to reflect on all of that and recognise what you've done well. If some of those processes aren't enough to actually relieve what you might be feeling around that experience, and that you're still walking around carrying some of that with you, consider going to EAP and looking at the other resources that are available through Bendigo Health. Go to your NUM, go to someone else and say, hey, I'm struggling a little bit, and get pointed in the right direction, because sometimes talking to someone else about it can help to relieve that. It's really important to care for yourself to be able to go on caring for other people.
So when looking for considerations for transfer of the patient from the emergency department, I guess one of the areas at Bendigo Health that we may be looking at to transfer the patient to would be down to the specialist palliative care and evaluation unit. So some of the things that we need to consider here would be, related to the patient. So we need an ambulance transfer for the patient to be able to, get from the emergency department to the specialist palliative care unit, which is, off-site from the main campus. And so is the patient safely able to travel? An ambulance transport does require transfer on and off a trolley. So that would be, in the emergency department, we would transfer onto the trolley. We would have to go into the ambulance, which can be quite an uncomfortable, bumpy drive, even though it is only around the corner. And then we would need to be transferred from the trolley back onto the bed down in the PAL care unit. This is quite a lot of movement for a patient, and if they are in an unconscious state, there is an increased chance that this patient may die on transfer. And so we need to make sure that the patient is well enough to tolerate this. And so generally, if a patient is unresponsive, we would avoid a transfer at this stage because it is likely that the patient only has a short number of hours of life left. So transferring a patient to a unit off-site is unlikely to be a benefit for them. It can be problematic if the patient dies in the ambulance en route, as the doctors on the receiving end have not met the patient. So the patient may actually then need to be brought back to the emergency department to have their death certified. And in this case, that can actually really impact on the patient's family's bereavement. If a patient dies on transfer, that's an extra 10 minutes that they may have spent in your department. So, really considering how safe it is for them to travel. Also looking at, specialist palliative care management. So often patients aren't always, end of life when we're thinking about transferring a patient down to the specialist palliative care unit. They may have come in for some pain control. So it's what is the appropriateness of them being transferred to specialist palliative care, or do they need to be transferred to a main acute bed and have further investigations done? So bearing in mind that if they do come into the PAL care unit, the radiology department is still located up in the main campus. And so we would have to be transferring patients backwards and forwards should we need those investigations done. So have we done all of the investigations required? Have we considered reversing all of the reversible causes for this patient's presentation prior to then accepting that this patient does just need specialist input from a pharmacological and non-pharmacological management that can be provided down in the unit, rather than is it more beneficial for them to be admitted under a medical or oncology team up on the main campus. Often, however, the patient may not be well enough or safe enough to transfer down to the specialist PAL care unit. And in this case, then we could consider a transfer to the ward. This is a much smoother pathway for the patient because obviously we don't have that, the difficulty with the ambulance transfer and that to and froing there. Often the patient may already be on a hospital bed if we've considered that they are end of life in your department, and therefore, they can remain on that one bed and taken upstairs. And we still do have access to specialist palliative care consultancy. So the team that Joe and I work for are able to come either to the emergency department or to the main campus to any of the wards and do a consult. And so, we would come up to one of the generalist wards, documenting the EPR, our recommendations for ongoing management of the patient. And so they still are able to access our team should that be required. And yeah, more than happy to talk to family and all of that as well at the time.
Discharge home for end of life is the other thing to consider is, when you're looking at a patient that is actually there's nothing further that's going to be done. We've optimized them as well as possible, and they really want to be home for end of life care. So consider if the patient is well enough for transport home. Of course, the same considerations that Anita's already spoken about. If they are an ambulance transport, it's going to be on and off trolleys, or if they're well enough to even somehow get into a loved one's car, it's still going to be quite an effort to get them home. So they need to be well enough to do that. But of course, if there's a window of opportunity, we would take it as much as possible if that's what the family and the patient are wanting. So discussion with family and carers regarding the care of a dying patient at home, helping them understand what it is that they're signing up for, what it is that it's going to mean to actually care for someone who is dying at home. If they have been providing that care already, they will have an inkling of it. However, it does intensify, and the amount of time that they would spend caring for someone does intensify. So it's always worthwhile having those conversations so that families and carers are on board, or they can actually have a discussion with the wider family and get some more people to help out with all of that. Consideration of anticipatory medications for discharge home. Important to think about what a patient might be needing, what we're anticipating their symptoms might be. Are we anticipating that there might be some further nausea, vomiting that might happen, and making sure they've got some subcutaneous medications, or are they already on a background of oral medication, which is working at the moment. However, at some point, they won't be able to swallow those oral medications. And do we have some subcutaneous options available to them to be able to change to that at home with support of the community palliative care and their GP? Ensure that they have a community palliative care team in place to provide support for them at home. If you're not quite sure who that is, this is a really good little trick to work out who it is. Just Google Pal Care Victoria or go to that website and put in the home postcode. Sometimes some of the borders around palliative care services are very different to the borders in the community. So it is helpful just to check in and see who might be able to provide that care. You actually find out the consultancy support as well, but we're really, it's really important to get them linked in with the community and ensure that their GP is on board to provide that care at home. If you have any further questions, please don't hesitate to contact us. There's our email address and there's our phone number. Unfortunately, we can't, this is where we'd normally have a chat, but of course, if anything comes up for you, please make contact with us. We're happy to chat with you at any point. And there's some references you can have a look at in your own time.
Thanks for tuning in today. And yeah, we look forward to seeing you again soon.
Thanks a lot. Bye.